Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the Department of Nursing at Salisbury University. I'm Dr. Mary D. Bartolo, Associate Professor of Nursing at Salisbury University and host of the program. Today I welcome back a special guest from the Department of Nursing, Dr. Judy Jarosinski. Welcome back.
Hi, Mary.
You were on the program before. We did a show,
Yes.
first in an addiction series, because we
Yes.
know that's a very important topic to discuss that's going on today in this area and across the country. And last program we discussed alcohol abuse. Today we're going to tackle pain medication abuse, which is probably number two, only to marijuana. And you said they're actually getting neck and neck now.
They're neck and neck, and opiate abuse is actually increasing even as we speak.
Well, tell us about, I guess just in general, prescription drug abuse. What does that mean exactly? And then we'll focus on the drug category of opioids or opiates, and so maybe talk a little bit about the anti-anxiety drugs like Xanax and Ativan. But I think we're going to talk more about the pain meds because that's a real issue today.
Okay. Well, when we talk about pain meds, we're usually talking about narcotics. And the role of narcotics in medicine is analgesia, which is just a fancy word for suppression of pain. The problem now is that people are using pain medications as a drug of abuse. And let's maybe go backward a little bit when we talk about a drug of abuse. Primarily when we go back to the Civil War or even in the Victorian age, we've always had drugs that are painkillers, and those were originally opium and opiate based. And then we synthesize morphine and codeine from opium. And then heroin was synthesized from morphine. So we know that addiction is part and parcel of these drugs. Today, we have not only the natural opiates, but we also have synthetic opiates, like OxyContin, like Dilaudid, like hydromorphone. So,
which is Vicodin.
Right.
Yeah.
So there has been, I guess, a progression in terms of addiction. Addiction has always been with us. We can remember when the Civil War soldiers, after battle, we had a number of addicts after the Civil War. In the Victorian age, what they would do was mix opium with alcohol, and they called it laudanum. And laudanum was used by many women. You can kind of remember those Dr. Brown syrup for women's cramps or women's ills. And many women use them for pain of childbirth or headaches or getting to sleep. So we had another crop of addicts, but we didn't know so much about addiction. And really, a woman could kind of sleep the day away and no one would think about it. But it became more prevalent when we look at history. And certainly one of the pieces of literature, Eugene O'Neill's Long Day's Journey into Night, he talks about his mother's addiction with opium. So addiction, it's been with us for a long time. What kind of morphed it up was in the 1940s, Demerol and Darvon were invented, and we had this whole crop of synthetic opiates. Now, people think that synthetic opiates are different from natural opiates. Well, actually, they're exactly the same. They go to the brain in the same way, they have the same outcome, the same effects, you have the same aspect of withdrawal and tolerance. And in fact, some of the drugs, like OxyContin or Dilaudid, are 50 times more potent than opium. So we're talking about drugs that are in everybody's medicine cabinet that people are taking very lightly. And so we've got young kids that are raiding their parents' medicine cabinet. They don't think it's a big deal because the doctors prescribe it. People who are on it and use it perhaps illicitly or not in the appropriate way don't think it's a big deal because after all it's not heroin or it's not a street drug. So bottom line, it's a problem. It's a huge problem today. We've got scores of young people addicted, and primarily it's gotten to be an abuse drug by young middle-class teenagers.
Well, I know I saw some numbers on the National Institute on Drug Abuse that they estimated 5.1 million people abuse pain relievers or pain pills, and it's probably a little more than that. This stuff's usually not generally reported openly, but that's what they're estimating, and that's quite telling. And I know the thing that concerns many people is the younger generation taking these pills and thinking it's okay. So let's talk about some of the problems associated. I know they have many effects, or maybe first, do you want to talk about the risk factors? Who's more likely to abuse drugs?
Well, the research indicates that people who are more risk-taking are probably more likely to use, are almost genetically predisposed. We also know that people who have fathers who are addicts are more likely to use. But on top of that, we have another whole piece about social learning, and that is that when individuals have family members, particularly parents, who view medication as kind of a way out. You can kind of remember when your dad would come home from work and he'd have that cocktail and go, oh, I really needed that. And that gave a message to the child that that was probably an okay way to deal with stress.
So take a drink or take a pill or whatever to relieve stress, and that's not a smart thing to do.
Right.
Kids pick up on that.
Yeah, and addiction is very insidious. We don't realize that with a prescription pain pill, just like heroin, the effect is exactly the same. You get a kind of euphoric feeling. We call that a rush. Your blood pressure drops, but you feel distressed. You don't feel anxious. You may have pinpoint pupils. You may be constipated. But the thing about drugs, I think, is very important to realize is drugs wouldn't work if they didn't work. In other words, that prescription pain pills and heroin do exactly the same thing. They put you into kind of a euphoric place where your problems don't seem to be the same, where day-to-day living is a little bit easier, where it doesn't appear to be a big deal. But the problem is that when you get that rush, you're going to need another rush 6 to 8 hours later. So in other words, because of tolerance, you're going to need the drug quickly just to feel the same or to keep from getting what addicts call sick. So it's the same thing we talked about alcohol, basically. You need more to get more, and then if you don't have it, you have what we call withdrawal symptoms.
So sick is just another term for withdrawal symptoms associated with pain med use. Okay. I guess the reason why it's such a concern, you're saying it's a younger population in this environment, and it can have a genetic predisposition. And of course, I think we still need to talk a little bit about the peer pressure involved, and the fact that I know they have parties where they come and put a bunch of pills in a bowl, and people feel pressure that you have to try different drugs, and I guess this access, two things right there, peer pressure and access to these medications. And you mentioned a lot of people have these medications in their cabinet from an injury or something, and they sit around and people either use them or sell them.
Right, they'll use these drugs for parties, and they'll put them in a bowl and then just take a bunch of drugs. Also, I think we've kind of talked about the younger generation, but prescription pain pill abuse, opiate abuse, is a problem with the older generation too. And we have some of these older folks that are going to their bridge parties or dinners, and they put their medications in a paper bag, put the bag up somewhere, and then somebody picks it up and they get cash. So there are problems with older generation individuals. People start at any time. So it's not just young people, but we get concerned about our young people because we know that this may set them up for, hopefully not, but a lifetime of addiction.
Now, what are some of the signs that someone could be abusing? Now, you mentioned some of the physical signs, but I guess things like, well, we know people can get prescriptions more readily these days, and sometimes people see different physicians and will get a different prescription. I think that's why there's this emphasis on getting some kind of centralized medical record, so that it might cut back on some of this going to different doctors and getting different prescriptions written up.
Yeah, that's absolutely what you'll see. If you have a family member who's taking prescription pain pills or has a stash, those will disappear. Sometimes there'll be fraudulent prescriptions. Sometimes some of these individuals will go from emergency room department to emergency department. We also call that doctor shopping, where they go from doctor to doctor. Sometimes they can get scripts on the via computer or online. So there are numerous ways that individuals can abuse drugs and find ways to abuse drugs. But you mentioned a little bit about, well, what's the picture you're going to see with someone who's abusing? And initially, family members will probably not see a lot. You'll see maybe changes in mood. You'll see things that are missing. You might see someone who's really a Dr. Jekyll, Mr. Hyde personality, and you might write that off as typical adolescent behavior. You know, nice one moment, and then they're craving, they need their drug, they're angry, they're hostile, they're lashing out at people, and they go get their drug. You may see money missing, jewelry missing, the TV's gone. These drugs, when you have an opiate addiction, or any addiction actually, but when you have an addiction, it costs money. And so there may be some illegal activity. You'll see people coming to the door, front door you've never seen before. Your kids will be involved with another group of people that you've never seen before. Those are kind of the warning signs, that personality change, things are missing. They're not involved in family events. They don't seem to be involved in the family. And they're very focused on their drug. And I think that's what we have to remember is being an addict is a full-time job. You get up in the morning, you crave your drug, you have to go and call a number of people to find out what dealers have the drug, then you got to find the money to get the drug or steal something to get the drug, and then you finally get the drug. So these individuals are very preoccupied with getting, using, and getting again.
Well, I imagine if they're in school, the grades are taking a hit, everything goes to the wayside.
Yeah, absolutely. You're going to see someone who's very lethargic. They'll be very tired. They won't have any interest. They won't have any curiosity. And then the same thing you'll see with somebody who is using as a middle-aged or older person. They will lack the interest in extracurricular activities or even home or life or family. And then sometimes family kind of get woven into it, and they kind of allow the addiction to continue because they can't believe it's happening.
Now you mentioned that at the expense of it, and I know I've done some reading and heard of stories where oftentimes people that have prescription or painkiller addiction will then move into heroin because it's actually cheaper than pain medication.
And this is the kind of thing that keeps people in what we call denial. There are two defense mechanisms that people with addiction usually get woven into, and that's denial, I don't have a problem, and rationalization, it's not that bad. So what you might hear from somebody is, I can control it, I only use on weekends, I'm not like a down and out addict, but the actual reality is 70% of addicts are fully employed. These individuals are not down and out individuals, and what starts as a prescription pain pill abuse can easily cycle into heroin abuse because it's readily available, because it's even cheaper.
And I know heroin, just, you remember that from the 60s and what an awful drug that was. But you're saying prescription pain meds are right, it's the same thing basically.
It's basically the same thing. Heroin is kind of enjoyed a resurgence recently among middle-class teenagers, and part of that is because they don't use it as an IV drug, but they snort it. And kids think that if you snort it, you can't get addicted to it. And that's absolutely wrong, that there are several ways to use these drugs. You can snort it. Some of these drugs you take as a lozenge, they call fentanyl lollipops, or other drugs you can use as IV, and there's a whole host of problems when you use them as IV. So we think of heroin, we think of that kind of down and out person on the street who's using it IV, but many kids start out by snorting it.
As an alternative to the more expensive pain pills.
Right, exactly.
And I know we were talking before the program, and I didn't know this. Of course, you were mentioning what are some of the street names for heroin per se, and that there's different kinds you can get, and some is more pure than others depending on where it comes from.
Yeah, people who live on the West Coast are more likely to get the brown heroin. They call that brown sugar, but the pure white heroin comes from New York City. So people in our area up to Virginia are more likely to have access to the pure heroin. the names, you might hear names like junk or black tar, smack, dragon. Those are some of the names. For oxy, they'll say oxy.
I know oxy's gotten so much press.
It has.
Partly because you had the oxycodone, and then they made a sustained, release
Time release, yep.
The OxyContin, and that has really, I think, taken off, more so than the other, because a lot of people just chew that to get a really, rush effect, I imagine. But, that's been a real issue in a lot of small towns, hasn't it?
Absolutely, Mary. I came originally from Virginia, and in small towns in Virginia and in West Virginia, you'll see towns decimated because there's a huge OxyContin abuse potential. And then we live right on 13, but there are, I guess the only word for it, are entrepreneurial businesses that set up in Florida where all they do is sell prescription pain pills for much less than what people can get them here. And much of that where they may have a front doctor. And it's very easy. I think the governor is trying to get a handle on it now, but it's been a problem for a while.
That's been in the news about these pain clinics in Florida.
Exactly.
And then it comes up this way, up 95.
And they actually will get the meds much cheaper than they will sell them up here.
Now, long-term effects, and not to mention what can happen, there can be overdose. So we'll talk a little bit about the long-term effects and overdose issues, and then we'll start talking about how to help people.
Okay, well, the long-term effects, you can have liver damage. We talked a little bit about that with alcohol last time. And Mary, as you know, the liver detoxifies everything we put in our body, including the oysters from the Chesapeake Bay and all those drugs that we take. So if you're taking Lipitor or if you're taking OxyContin, your liver is still going to have to detoxify that drug. And it's interesting when you think about it, but even a half a glass of wine or liquor is enough to cause the liver to have to really work hard. So imagine what it's like for somebody who's using huge amounts of this drug. Pain pills, opiate pain pills, and heroin are unique in that you need to have large amounts and you can actually build a very huge tolerance. So people build up rather quickly to this huge tolerance so they can use huge amounts that would fell an elephant. And what happens is that when they are clean and sober for a while, if they go back to that previous use, they can actually have an accidental overdose. And that's how overdose happens.
And we've heard a lot of these stories, tragic, in the celebrities and such.
Absolutely.
Yeah.
Absolutely.
So let's talk about how to help people that have an addiction, particularly to painkillers. What are some of the ways that people can get help to stop this? Well,
I would say that families need to really get involved and really need to work on an intervention with their loved one. It's not easy because families can end up being very codependent and kind of support the addict. And what you want to do is not make it too comfortable for the addict and help them get help. When they get help, whether that's an inpatient substance abuse clinic, whether it's NA, a lot of times addicts feel...
When you say NA, you mean Narcotics
Anonymous, yes. A lot of times addicts think that, well, that's it. All I need is this 24-hour detox, and then I'm fine. In actuality, detox is the very first step to recovery. Because what's happening, and we talked a little bit about this with alcohol, and it's the same way with alcohol, that these narcotics send messages to the brain in which huge amounts of dopamine are released that kind of make the individual feel euphoric and happy, etc. But when the brain keeps doing this, then nothing else can really take the place of that euphoric feeling. So recovery is going to take a long time. At least 90 days before the brain gets on target. You're actually, by your own addiction, you've actually kind of rewired the brain. So that's part of the piece, is you've got to have a good long recovery, so you need a lot of support. And when I talk about support, I'm talking primarily about group work, going to the meetings. I know sometimes individuals feel that they can do it on their own, and yeah, there are people who can do it on their own, but it's very difficult.
Now, are NA meetings a separate issue from AA meetings, or are they all lumped
They
together?
have the same 12-step component, so they have the same philosophy. But a lot of clients, they like to go to either the NA or the AA, but you can go to AA as well. What I would really recommend if you go to an NA meeting is be patient. Sometimes people say that I didn't like the meeting, everybody was talking their old war stories, but be patient and seek out somebody who can be a sponsor for you and help support you through your recovery, which is, by the way, a lifelong process. And that's what addiction is. It's a lifelong process. And sometimes what I'll find are some of my clients will find a home group that's maybe far away from their own home, or where they find they're very companionable with these group of people. They get along with this group of people. So find an NA group that fits you, that works for you. So don't give up the first time you go to NA, and also don't give up if you've had a relapse. Relapse is part of recovery. You learn new tools every single time. So don't give up, and the family needs support, but don't support in ways where you actually keep the person from really getting into recovery.
So the support piece is big, but of course there are some medications that they use to help people kind of bridge that gap. And I know methadone, most people have heard of that in terms of helping with heroin. Talk a little bit about methadone, and then there's some other drugs out as well.
Right, and what we find is methadone is similar to opiates, and it kind of sends the same message to the brain. But what happens is when these individuals are going to a methadone clinic every day or every other day, they're able to get a job. They don't have to use a drug. So it's kind of replacing the drug in a way. And you'll have these methadone clinics, and they may go to these methadone clinics for a very long time. So a lot of people become concerned, well, aren't you just replacing one drug for the other? But they're actually able to get a job, be able to be functioning in society. When you're an opiate addict, you cannot function. The other one is LAM, which is a kind of type of methadone drug, and that's a lot of individuals like that because you don't have to take it as frequently. And then there's another one called buprenorphine or Suboxone, where individuals can take it in an inpatient setting, and they do have some outpatient clinics. And it's sublingual, that means you take it under the tongue. So there's a couple of options. People don't have to go cold turkey. And cold turkey, by the way, comes from the descriptions of people who were withdrawing from opium. The little prickly bumps when they had
I was always wondering where
that
came from.
Yeah, that's where they came from, the sweating and the cramps. And that's what keeps people from sometimes getting into recovery. They're very, very afraid of the withdrawal symptoms because they will have cramps. They will feel very sick. They'll be nauseous and vomiting. And they're so scared of that that the alternative is to continue taking the drug.
That seems like the better alternative.
Absolutely.
Yeah. Now, I know alcohol takes, what, five or 6 days. What about the withdrawal from pain meds? About how long does that take? Or heroin, the opiates?
Well, that can be with buprenorphine in inpatient setting. You may take it for 3 days or 5 days. But the real work occurs when you get out of the clinic. And I think that's the message that we have to tell our individuals who struggle with addictions, that while you may have these stopgap measures, the real work is working on their personal recovery plan. It's to making that drug not a part of their life ever. And that means drugs that are similar, even alcohol, because of what we call cross-tolerance, because they're similar drugs. So there's no, it's not, some people are on methadone, not as cut and dry, yeah. Some people are on methadone for years, and then they wean off methadone very, very slowly. So it depends on the individual, it depends on their own recovery plan.
And there are experts at this, like if a family member suspects, sees some of these signs you mentioned earlier, and of course they should see their primary care provider, or is there another resource in the community they should go to where there's experts on addiction and withdrawal and that kind of thing?
Yeah, I would go to Narcotics Anonymous because it's free. You can go to a meeting, but you can go to, if you want to go online, to NIDA, NIDA, or SAMHSA, SAMSHA. They have a lot of information. And look at your community resources. There are withdrawal clinics all over the place, and many of them are not expensive. Even the Betty Ford Clinic takes patients gratis. So many of them will have a payment plan that works for you, because the bottom line is many people with addictions can't take time off work if they have a job, and are very afraid of that, but you can't continue with life until you get clean.
Just to clarify one point, Judy, we were talking that most of these pain meds are taken by mouth, aren't they? But you were mentioning to me earlier today that they can be taken IV if they're crushed and dissolved, and that's really dangerous? Yeah,
absolutely. Individuals, in fact, I knew of a person who was a nurse, but you can crush these medications and take them IV in a solution. And taking any of these drugs in an IV form, not to mention the usual risk factors, you have another host of risk factors. You can cause inflammation of the vein, infection, endocarditis, you can do heart valve damage, you're introducing susceptibility if you use dirty needles, and even professionals use dirty needles, and they can be susceptible to hepatitis B, hepatitis C, HIV, even tetanus.
Well, it sounds like, we know, I think most people know heroin's dangerous, and you're saying, that can be actually snorted, or people resort to that. And then, of course, these pain medications, people are under the false assumption that they must be safer because they're by prescription, or because they're quote-unquote legal, but it's not legal. It's illegal to use, a prescription drug without the actual prescription.
Absolutely.
And such. And of course, they have, a lot of short-term and long-term side effects, including overdose, obviously, and death. One other group we mentioned briefly in the beginning, we don't have time to cover it today, but it can be just as much of an issue as abuse of the benzodiazepines like Xanax, Ativan, and Valium, and these are used for anxiety.
Yes, there's a lot of potential for abuse there, because they're also prescription medications, and so people are also exercising the same defense mechanisms, like denial and rationalization. It can't possibly be that bad. But you see the same kind of picture, escalating use, and then they're doing things to make money, to get more drugs, so they're doing the same things we talked about before. Fraudulent scripts, computer-generated scripts, doctor shopping, going from ED to ED.
And then you're saying if you see any signs of mood swings, the Jekyll and Hyde, and some of these other side effects we talked about, and hanging with different group of friends, and different activities or secretive activities, then you should, think about prescription drug abuse.
Absolutely, Mary. You're going to see your loved one hanging around with a different group of people. They're also not going to pay as much attention to their own clothing, to their own hygiene. They may be very lethargic. You'll see pinpoint pupils. They're not going to be with family. They'll be in neighborhoods they never were in before. And then, very strikingly, real behavior changes.
And aren't there people that actually specialize in this kind of thing, whether you call it an addictionologist or addictions counselor?
Absolutely. These people are trained to deal with addictions. They've seen every case scenario. What you bring forward is not going to be any different than anybody else. And let me just add that many of these addiction counselors have actually had to deal with the addiction themselves. So they're expert at the denial and rationalization. They're expert at how they came to be clean and what the recovery process is like.
So I imagine they'll be very empathetic to what the person's going through, which I think is important.
Never give up, and never be hesitant to get help. There are specialists, and in fact, one of my favorite addictionologists was an alcoholic himself, and he was very capable of understanding what that process was like.
Well, what we'll do is post some websites at the end of the program where people can get more help. There is tons of information out there from the National Institute on Drug Abuse and various other websites no lack of support or information for people that are going through this, because it's very tough.
Mm-hmm.
Well, thank you so much, Judy,
Thank
for being
you.
on the program.
I enjoyed it.
And thank you for joining us for this edition of Focus on Health here on PAC 14.
Focus on Health is sponsored by Peninsula Regional Medical Center, a proud supporter of PAC 14 programming.
Hi, I'm Peggy Nalepa, President and CEO of Peninsula Regional Medical Center. PRMC is privileged to partner with PAC 14 to provide educational healthcare programming for the Delmarva region. Peninsula Regional Medical Center, a proud supporter of PAC 14 and public access television.